So welcome back to the Dr. Doug Show. Today I've got a great interview for you. Today I interviewed Dr. John Neustadt. So Dr. Neustadt has been in the bone health space for a long time. He is the founder of a company called Nutritional Biochemistry Inc. It's NBI. He's created products. He has written over 100 medical articles. He wrote a book called Fracture Proof Your Bones, A Comprehensive Guide to Osteoporosis. He's actually working on the second version of this book right now. So I really wanted to interview Dr. Neustadt because he's been in the space for a long time. He's seen what works, what doesn't work. He's been speaking at conferences for years on this topic and is really one of the leaders in the space. So join me for this. We talk about what I tried to frame as sort of the 5 most powerful tools you can do for your bone health. And we talk about a few more than that, but some controversial things in there, some areas where he and I don't necessarily see the literature the same, but I hope what you can find is the nugget in there that works for you. So take a listen to myself, Dr. Neustadt. Thanks for your time. All right. Well, Dr. Neustadt, welcome to the Dr. Doug Show. I'm really happy that you're here. I was excited to learn about your work, which it seems like I was really late to the game in because you've been doing this for a long time. So let's just start here. Tell us a little bit about how you got into this space and what really precipitated you writing the book that we're going to talk quite a bit about.
About 20 years ago, when I was just starting out in clinical practice, I was seeing patients who were coming in with bone loss and osteoporosis. And I think like most of us, when we're first starting out, we just were doing what we were taught. And so I was working with them and their bone density was going up. So I was happy and they were happy. And my mother-in-law at the time, she had osteoporosis. I was helping her with some nutritional recommendations and some exercise advice, but she was working with her physician and was taking Fosamax. Her bone density was going up. So everybody was happy. She was happy. Her physician was happy. I was happy. Everybody thought she was protected. And then she slipped and fell on a throw rug in her house and broke her hip. And I thought something is wrong with this picture. So I started diving into the research and I was absolutely shocked by what I found. And this is since the 1990s. It's been in the research that a bone density test predicts less than half of patients with osteoporosis who will fracture. And then more recently, 2008, a study came out that quantified that a little further. And now we know that a bone density test only predicts 44% of women with osteoporosis who will fracture, and only 21% of men. And every association that's an organization that has looked at this issue has correctly concluded that fracture risk depends on factors largely other than bone density. Yeah. And breaking the bone is the most dangerous thing about this, not a number on a test. So I just kept going and trying to learn more and more of how I can help patients and what I can do to address this issue that is undertreated, but also mistreated. 95% of patients, Medicare eligible patients, aren't even screened for osteoporosis with a bone density test. So it's something that needs a lot of attention. I'm thrilled to be here talking about it with you. I know that you are very knowledgeable and deep in this space too, and it's wonderful to have this conversation and collaboration with a peer who understands that there's a lot more we can do to help patients, and it's really needed.
Yeah, well, I'm excited to talk about what you've learned from the literature because similarly, when I started looking into this, thinking, gosh, is this a population of people that I can really help? I similarly was just blown away by what the literature says regarding what we can do versus what we are doing and recommending. And then when I started talking to patients, especially after we started the YouTube channel and we start seeing all the comments, the fear that comes along with the diagnosis of osteoporosis, the change in life and lifestyle that comes along with knowing that someone has low bone density is disturbing for me because so many times I don't think it's necessary. I think we're looking at the wrong thing. Like you said, DEXA is a piece, bone density is a piece, but we don't really even know how big a piece that is. Maybe it's 40%, maybe it's less, maybe it's a little more, but it's probably not the biggest piece.
Yeah, it's definitely not. And I agree. I mean, patients are so scared, and I understand it. I mean, if you're a woman with osteoporosis and you fracture a hip, there's up to a 36% chance that you're going to die within a year. The most frequently cited figure is 20%, but it goes all the way up to 36%. And about half of those patients who survive never regain their full pre-fracture level of mobility and pain-free lifestyle that they had. And many people know a parent or a grandparent who had osteoporosis and broke a hip, and that was sort of started the downward spiral, and it is scary. What I do when a patient comes to me with a bone density test is I first have them take a few breaths to calm down, and I put that bone density test, like we were already discussing, in its proper perspective, and I let them know that this is serious, but it's not an emergency. There is time to put together a holistic bone health program that makes sense for them, that may or may not include medications, but there's time for them to educate themselves, understand what they can do, and make decisions that are informed and educated and that they're comfortable with.
Yeah, no, I love that. And I do kind of the same thing. I mean, it's one of the things I try to educate on so often is, look, before you freak out, before you change everything and stop doing the things that you love to do, let's actually figure out what's going on. Because again, density is just a piece. It's not probably even the biggest piece. So yeah, then I'm happy about that. We have that same approach. What I'd love to do, John, is, we could talk for hours and hours and just dissect all the things that we do and learn. But to keep this succinct, I think maybe if we just focus on, let's just pick 5 things, and I'll kind of lead and you can steer us as you see fit. I think the most important thing is, when I say we need to learn more information, I have a process that I go down, but I'd love to learn kind of what you think from it, like an imaging or biomarker or testing perspective. Like, what can people do to help learn more about their bone health?
I love this question. All tests have their limitations. And the question I always have with a test is it going to change our approach to treatment?
Yeah.
And how predictive are the test results for fractures? Most of the tests that are just single tests are not very sensitive or specific to fractures. And when you look at combining test results, that's when you can get a greater association with fracture prediction. But the biggest benefit I find for testing is really to raise awareness for patients and to start the conversation, and for patients to be able to be motivated if they need those test results to help them focus on what they can do to improve their health. Because with all of the imaging, for example, everything's compared against a bone density test, which is the gold standard. And nothing has been shown to be superior than a DEXA at predicting fractures, which we've already discussed is severely limited in itself. There is an emerging technology called REMS that I'm sure you're familiar with, but it's only had 2 validation studies on it, and only one has shown superiority. So I think that's a great future possible technology that can be very helpful.
Yeah.
The other tests that can go that are run, like these biomarkers, bone turnover markers, CTX, NTX, they are highly variable, and the current recommendations for the International Federation for Laboratory Clinical Chemistry is that these biomarkers should be used for treatment monitoring primarily, not for screening or diagnosing. It's more for compliance, because as you're probably aware, they're so sensitive to various changes, and there's no standardization in terms of the values, what is normal. They also change just based on the time of season, or if a woman's still having her period, the phase of her menstrual cycle. They can change if somebody ate or exercised in the 48 or 72 hours prior, if they've fractured within the last year. So there's just a lot of changes, and just on the same machine, the coefficient of variation, that is, how much the samples can change. Even the same sample, when tested, is in some cases 15-20% or more. So I just think that those bone turnover markers should be used very cautiously. And I think that too many doctors are in love with testing. This is my personal opinion. And they overtest, and they put too much emphasis on the testing and the test results instead of treating the patient holistically. Of the testing that I do run and definitely recommend is vitamin D testing. Want to make sure that is up in that healthy range that's associated with maximum fracture reduction. Run a CBC and chemistries and basic panels like that. But the older I've gotten, the less testing I do.
Yeah. No, that's great. And we have a similar trajectory. We're probably earlier in it. So when we initially started the program, I love data. So I'm just, I'm the guy that has worn Aura and Whoop, and,
Yeah, I
I
love
do
it.
my full panel every 3 months, and I just love data. And so when we started this program, I did the same for my patients. I said, I want to see all the data. And I think that there's value in it, but the first thing you said is really important, is if it's not going to change your treatment plan, why do the test? And I've found over time that some of these things aren't changing our treatment plan. So we have been able to, trim it down. And there is a future I see where we have a much less aggressive program of treatment that is going to be more recommendation based. And that's why even when we have a community called the Osteo Collective, and even in that community where we're not providing any medical care, we still see improvement because they're getting the right information, the information that we know is going to be helpful. A lot of that we'll talk about today. So yeah, I think it's this interesting trajectory from a clinical perspective where, do I need a DEXA and a REMS, the bone turnover markers every 3 months, and this panel and that? I think it doesn't necessarily change what we do. I just want to double click on that bone turnover marker conversation. I'm excited about them. We do use them, but I often caution my patients to say, just because they don't look like the way we want them to doesn't mean that you're not headed in the right direction. So we have to just take them for what they are, knowing that they're variable. And then the other thing we say about them is we need to test them under as many of the same circumstances as possible, so that they are in morning, fasted, dinner the night before was the same, the last time you worked out the same. Try to eliminate as many of those variables as possible, because what I do find really valuable is that ratio between, we use CTX and P1NP. That ratio between building and breakdown can help to steer us, or, to be more aggressive in one direction or another. So I think there's value there. I just don't think we know how much value there is right now.
Well, and I love hearing that with your approach, and it's very sophisticated. I think how you're talking to your patients about it, and how you're using them. One of the challenges with these bone turnover markers is their breakdown of fragments of proteins from bone. And one of the challenges is that there are 180 to 200 different proteins in bone, in addition to collagen. And so, boiling it down to just one or two little fragments of those that are involved in bone formation and bone strength, I think is a real big lift. And I think that people give them too much, like I said, emphasis and weight. I mean, some patients have come to me and said, well, my doctor looks at the ratio and told me that I'm a fast bone loser right now. I'm losing bone quickly, but that'll slow down over time because I'm just, going through menopause. The research, though, shows that the ratio of those bone turnover markers in terms of their ability to predict whether somebody is losing bone quickly or slowly is only 50%. So even for that, they're really not very sensitive or specific. And again, I'm not against testing. But I think for me, what I've learned is the best value for testing is to raise awareness and have people continue to, move down a path towards taking care of themselves, taking charge of their own health, because most of the research that has looked at this issue in terms of what is the most predictive of fractures has nothing to do with any of the tests. The most predictive of fractures, most consistent indicator in the research for future fractures is gait and mobility. And because 95% of fractures occur because somebody falls. So that gait and mobility piece, that strength training, making sure they've got enough protein to build muscle, making sure that they have the right footwear, making sure that their home is fracture proofed and there's, they're not going to trip and fall on something, or the pathways are well lit. None of that has to do with testing. And I think that in terms of a holistic approach, testing is one piece of, I think, as we both mentioned already, just a much larger puzzle. And my concern with patients and not yourself in particular, but yeah, I was just lecturing at a medical conference on osteoporosis. And it was really clear to me on the questions I got from the Q&A afterwards is that the doctors themselves were so focused on the testing. They could break away a little bit from that and realize that the testing in this situation, osteoporosis, is extremely limited when it comes to fractures. Now, you can get some better improvement in predictive value when you're combining test results like a low serum estrogen with a low bone density, low T-score, and an elevated CTX. That's more predictive than CTX alone, or more predictive than DEXA alone. But even that, what are you going to? How is that going to change your approach to treatment?
That's a great clinical example. So we do see, especially in our first lab panel, we're always having this question around what do we do with hormones? And because a lot of times our average patient age is probably mid to early 60s, right? So this is the population of women who usually weren't offered it because they were within a decade of WHI. So now they have osteoporosis and regret around not having that conversation. So we have this conversation a lot, and it is compelling to look at the labs and say, well, your CTX is 1,000. Your estradiol is 0 because you're postmenopausal and not on replacement. So this is something that we could follow and say, well, if we give you estradiol and we follow your CTX, it can help us to dial this in a little bit. How much estradiol do you need for your CTX to start dropping? And for some women, it's not very much. For some women, it's more. But we do put all of the pieces together like that. And that is why I do kind of like this more extensive panel. But again, I think there are a number of those things that we can cut out.
I think that's a great example of how to use the testing correctly. And how to use it in a very targeted manner. So yeah. I think what you're doing and what you've created in terms of that protocol or that example is fantastic.
Well, and here's a nice, the converse side of that. So let's say we have, a similar woman, mid-60s, her CTX is 250, which is quite low, but she's not on HRT. I can't tell her that going on HRT is going to change her CTX because it's probably not going to make it go down anymore. Right. So then maybe we have a less compelling argument to use it for that reason. So I do find them helpful, but I agree they're limited, and we have to really take into context what the situation is in which we're measuring them.
But what about if her T-score was also low? Because we know that HRT will improve a T-score.
Yeah. And so this is some of the space we don't know. So we know, yes, of course, there's so much evidence looking at estradiol specifically and bone health. We know that it'll help to increase bone mineral density, and we kind of know it reduces fracture risk. Not enough studies on that. But we don't have a great understanding of in which population is this most beneficial. Meaning, if you were to take that second case where her CTX is already low, is that patient going to actually see the same benefit as a woman who is, a quote unquote high turnover? Probably not. I still think there's benefit. And we don't know how to objectify this at this point, and probably never will. But I would have the conversation with both for sure. But I would have when I see a CTX of 1,000, I can tell the patient, look, the most powerful tool for this is going to be HRT. And I mean, hands down. For the other patient, it's, what's it going to change? Well, it's going to change a number of things, but it's not going to bring your CTX down appreciably.
Well, it's interesting because, as you know, estrogen does a lot more than just collagen, help promote, collagen production. And I think clinically it is a very challenging, case and situation to make those decisions. And there is a limit, of what we know and what we don't know.
Sure.
And with estrogen, we do know that, it's associated with a 28% reduction in hip fractures in women who started it during perimenopause up to 60. There's no data that I've seen after 60. And so, not everybody fits those clear definitions. And in those studies, they didn't look at CTX. So you're absolutely right. But other things that estrogen does, for example, vitamin K, when estrogen is low, vitamin K absorption goes down. And it's very clear that vitamin K is required for strong bones. And so, estrogen, it's interesting. I can see it both ways. Do we just do prescribe estradiol because of perimenopausal symptoms, vasomotor issues, and high CTX, or are there other ways or reasons to justify doing it even if it's low dose? I don't have an answer for that. But I think it's a very complicated clinical situation.
Yeah, it's one we've really had to tackle head on because we have a patient population that is within 10 years of menopause, and then we have lots of patients who are 10 to 20, and we have patients that are over 20, and it's a different stratification. for each of these patients. So let's maybe just kind of switch gears a little bit, because I have some other hormone questions I'd love to pick your brain on. So my goal today was we're going to talk about 5 things. So we talked about imaging. So number 2, then let's talk about hormones, because yes, estradiol, very powerful. HRT is absolutely a controversial space. So let me just ask you, where do you land on this? Where have you seen this to be helpful or potentially harmful in certain circumstances?
So HRT, specifically hormones, is a big issue, and I'm assuming we're just talking about HRT here.
Yeah, let's just narrow it.
there are lots of hormones, as we both know. But with HRT in both women and men, I'm a fan of it when it's indicated and when it can be done safely. In women, as I mentioned, the research is clear that there is an association with a reduction in fractures and improvement in bone health. When to use them and in which clinical situations to use them, as we've been discussing, is not always clear cut. And I think that in men, testosterone replacement when testosterone is low and their symptoms is also a good strategy. Interestingly, in the studies with testosterone in men, fractures went up in the first year. Not because of the bone effects of testosterone, but the speculation was because the men were feeling better, they had more energy, and men tend to make more reckless, dangerous activities and decisions that
Indeed.
we stopped doing, but we went back to if we were feeling 20 again, we'd be doing that again. So that's what the research showed with that. But it's also the estradiol in men is really important to test and keep above 20. So that's what I would want to track with both of those.
Yeah. So my experience, we started out, most of my patients, before we really narrowed down and focused on osteoporosis, most of my patients actually were men. And I was trained with testosterone replacement therapy to consider using aromatase inhibitors to kind of limit estradiol. So I was trained in this space where estradiol wasn't necessarily great. We didn't want to kill it, but we didn't want it to be high. I have a totally different perspective now, right? Understanding the value of estradiol in men. And what scares me is a lot of my colleagues, and especially over in the fitness space, a lot of recommendations around TRT is to essentially eliminate estradiol with AIs. So I'm seeing all these guys that have, a testosterone, a total T of 1200 and estradiol of 0. And I think this is a huge problem. We're going to start seeing a lot of sort of the fitness people that are using TRT, maybe even inappropriately, but eliminating estradiol, and they're going to have early bone loss. There's no question.
Yeah, it's not a great, I don't believe that's a very great clinical approach by any means.
Yeah, we haven't used AI in a long time, but
I've seen cases of their estradiols gone a little too high. They end up with some nipple tenderness and a little bit of gynecomastia, and so we just pulse it. We'll give a milligram every few days for a couple weeks, and that's it. And then we retest every 6 months.
Yeah,
anyway.
but then watch the levels too, right? So your estradiol is going to stay above 20.
Yeah, that's kind of the goal. I personally don't like to see it above 40. I mean, that's kind of where 20 to 40 seems pretty good.
I have some guys that do fine 40 to 60. I don't see anybody, no matter what their testosterone is, I sort of feel like there's a limiting enzyme in there somewhere that it doesn't really go. It's not linear with testosterone levels. So that's great. Any downsides that you see other than men being reckless on testosterone, any downsides that you see from this perspective for especially for women that are considering HRT? What do you counsel from a risk perspective?
Well, if they have a history of breast cancer, hormone sensitive, cancers, not just breast cancer, then it's a real concern. And I always I refer out for those because that's not something that I feel comfortable with. I don't want to prescribe any estradiol in a woman with a history of that. So, I mean, that's really, for me, the biggest concern. For men in cancer, it's not considered a concern anymore. Testosterone, that's been debunked. Right. And that's really it. I mean, for me with women, I don't know, do you have other concerns?
Yeah, so that one for sure. And our approach is we do prescribe for some women that have had a history of breast cancer, but we have some cutoffs, on what, stage grade, initial treatment, et cetera. And then we also have an oncologist that we have not on staff, but someone that we can refer to that can help us to really determine very accurately what their risk of recurrence is. And then we let them make a decision based off of that.
But if I can just add to that piece of the HRT, while I think HRT is can be a helpful component, I by no means think that it's necessary to reduce fractures as much as we can. The research is clear. We can get over 70% reduction in fractures without HRT. So I think that HRT is great, but I don't think it's a necessary component of a program.
Yeah, well, that's great. And I agree. And because we are monitoring and tracking everybody's biomarkers and imaging. And I agree that we have women, 60s, 70s, even 80s who are seeing improvement in bone, in muscle mass without HRT. So I agree, not required. I think it does make it easier, but not required. So then, all right, so we talked about imaging, we talked about hormones. Let's talk about your choice. What do you think is one of the more powerful tools that you would like to talk about with the audience, specifically for bone?
That's such a great question, and it's really hard for me to pick just one because all the tools are interconnected. It's a holistic approach, and they all feed off of each other, and they all help support each other. So diet and lifestyle for me always the foundation. And a Mediterranean dietary pattern is associated with a 21% reduction in hip fractures and a 20% reduction in osteoporosis. So I always talk about that diet. There's been that dietary pattern. There's never been any negative study that I'm aware of with the Mediterranean dietary pattern. It's associated with a reduction in Alzheimer's disease, cancer, death from cancer, all-cause mortality, diabetes. I mean, you name it, just on and on and on. So I think that dietary component is really crucial. Movement and exercise, crucial. You don't have to go to a gym, but even walking 7,000 to 7,500 steps a day is associated with a 50 to 70% reduction in all-cause mortality. So exercise, healthy, safe exercise is important. Then sleep, crucial. Not getting enough sleep is associated with faster rates of bone loss. And then supplementation. I'm very conservative when it comes to supplements. I know some doctors prescribe a lot of different things. I've looked at the research and I've settled myself personally on prescribing and actually created products because they didn't exist in the market. Products, I look at the nutrients and ask the question, which ones have been shown not just to improve bone density, but reduce fractures in clinical trials and have been shown to be safe. And so, one of my bone support products, Osteo-K Minis or Osteo MK4, that is also First Line that I recommend, along with those other approaches that I mentioned.
Yeah. Now, in the supplements, because everybody loves to talk supplements, in those supplement lines, I've looked at the products, and correct me if I'm wrong, do you lean on the research for MK4 as for K2 as MK4 in those products? Is that right?
That is correct.
Yeah. So give us your interpretation of the literature there, because a lot of people will say MK7, longer half-life, better, but there's more research on MK4. So tell me how you landed on that formulation.
I love this question, and I give CE talks even on vitamin K in cancer, vitamin K in bone health, clarifying the vitamin K confusion. Those are all topics that I've lectured on, and there is a lot of confusion out there. You mentioned half-life. MK7 does last longer than MK4 in the body. That is true. MK7 may be more bioavailable, means it might be absorbed more, but the study that showed that was flawed. But regardless, neither of those are clinical. Those are all just things in a lab, in a more pharmacokinetic, pharmacological type data. They're not clinical outcomes. So as I mentioned, the way that I look at the research and think about it is, first, what's been shown, most importantly, to reduce fractures. And yes, should it improve bone density? We'd love to see that happen as well. So what did the research show for MK7 versus MK4? All forms of vitamin K will change laboratory markers. We've been talking about them. Any of the laboratory markers that are dependent on vitamin K, like undercarboxylated osteocalcin, all forms of vitamin K will improve that. But again, that's not a clinical outcome. MK7 in all the clinical trials that have been done, in every dose, has been shown only at the very best to slow down how fast somebody loses bone. It slows down bone density loss. And there was even one study where the women lost bone density of the hip faster when they took the MK7 versus the control group. And there are no studies, no outcomes data at all showing that MK7 reduces fractures. Now, MK4 and MK7 are both types of vitamin K2, but they're different molecules. And what we know in biochemistry is if you change even one carbon atom on a molecule, you can get overlapping benefits, but you also get very different effects. And this is a great example because when you look at the clinical trials on MK4, 45 milligrams per day in divided doses, what it shows repeatedly over and over and over, not only does it stop bone loss on a bone density test, but it improves bone density in postmenopausal women with osteoporosis. And it's been shown repeatedly in medication-induced bone loss from prednisone and androgen deprivation therapy to stop bone loss. But more importantly, studies have shown, and there have been several meta-analyses that have now been done, that MK4, 45 milligrams per day, can reduce fractures by over 70% in postmenopausal osteoporosis. And that's incredible. It's not sick, it's safe. And when it's combined with vitamin D3, the benefits on bone density are even greater than when MK4 is used alone. So that's why I use MK4. This was 20 years ago. I was looking at the research, and there's been more since then. MK4 has been approved by the Ministry of Health in Japan since 1995 for bone health. And when I was looking at this issue, no product existed in the U.S. with that clinical trial that I needed to help my patients. So that's why I created my company. And that's why.
Well, and that's where Japan is where most of the larger studies have been done on that 45 milligram dose, right? Yeah.
Correct.
Yeah. They're way ahead of the curve there. So let me ask you this question, because I get this question all the time, and I know the answer, but I want to hear you say it. What about blood clot risk and vitamin K?
There is none. If somebody has healthy blood clotting, there's no risk. The enzymes for blood clotting, they become saturated. I mean, once you have enough vitamin K for healthy, normal blood clotting, it's like a conveyor belt. It can't go any faster, can't clot anymore. There have been over 25 clinical trials with MK4. 45 milligrams have been even used up to 135 milligrams in certain oncology or cancer populations, and with no adverse coagulopathies, no adverse coagulation. I've had no side effects at all.
Yeah, I agree. Yeah, I've looked at this extensively as well. And yeah, there is no signal there. It is, I think, all comes from all of us doctors that are trained to use Coumadin or warfarin, and talking about vitamin K in those patients, and it just has really just blown up from there. So then let's switch to vitamin K1 then, because I see some recommendations for K1. I don't think you have K1 in your products. What's your take on that?
No, because vitamin K1 has never been shown in clinical trials to reduce fractures. There is dietary, epidemiological data showing that, every 50 microgram consumption increase in vitamin K1 consumption in food is associated with a 3% reduction in fractures. And so I recommend, but if you look at the clinical trials on K1, it doesn't show that benefit. We see this acting quite a bit with different nutrients. The nutrient in food, people, is different and behaves differently than in a extract or just an isolated nutrient in a pill. And it's also very difficult using how these studies are conducted using food frequency questionnaires and databases to really be that precise in terms of which nutrient is giving the benefits that we're seeing.
Yeah, for sure. And I kind of feel the same way. I think there's value in eating vitamin K rich foods, but I've not found the value in supplementing K1 specifically. All right, let's stay on the supplement line for a minute. What other products, so I know I haven't looked at your product line in a while, but I have looked at it. What other products do you think are valuable? Because this is a population of patients who really enjoy looking at the research on supplements and taking supplements where appropriate. So what else have you found to be valuable?
So calcium, I think, is helpful. I mean, calcium and vitamin D are associated with or have been shown to have an 18 to 23% reduction in fractures. But not everybody needs calcium as a dietary supplement, and I really caution people about taking too much calcium. The current position statement of the Bone Health and Osteoporosis Foundation, of which I'm on the corporate advisory board for that foundation, and the American College for Preventive Cardiology, is that people should not get more than the tolerable upper limit of 2,000 to 2,500 milligrams per day of calcium. And that's from all sources. I think that a lot of people lose sight of that the RDA is, from diet plus dietary supplements. The average American woman consumes about 800 milligrams of calcium in her diet. So maybe getting an additional 400 milligrams of calcium as a dietary supplement could be beneficial. Get her into that sort of healthy range. Even if you don't calculate it precisely, how many milligrams does she get through diet? You could supplement with that amount and still not, be up anywhere near that threshold of concern in terms of the total.
Yeah, amount. And what forms did you end up using in your product?
I like citrate. There's no evidence that one form of calcium is better than any other form when it comes to fractures. So I just want to say that. Why did I use citrate? I use citrate because as people get older, the prevalence of low stomach acid increases.
Right.
And especially if they have any other diseases like autoimmune diseases, the risk for low stomach acid goes up. And obviously if they're on acid blocking medications, which are common in the elderly. Citrate is absorbed in a basic pH, more basic pH. And so you can really still get the absorption of that nutrient and not have to be concerned about what their stomach acid pH or stomach pH is.
Yeah, no, I agree. Carbonate is very difficult to absorb for a lot of people.
And also if people have a history of kidney stones, oxalate kidney stones is the citrate form of the nutrient that is considered safe and is what's recommended.
Yeah. So then what are your thoughts on some of the newer products out? So like the microcrystalline hydroxyapatite complex, the MCHC products that are out there, or the algae products that are out there?
I think that they are showing you bone density test results. None of them have fracture data on them. And to me, that's the most important piece of this puzzle. I always go back to that. When it comes to the algae type of products, it's the calcium from algae is basically calcium carbonate with trace minerals in it. And same with the other forms of calcium that are out there in terms of the data that these companies are providing. They're all that I've seen, they've all just been bone density data. There's another nutrient out there that you see, strontium, that's in some of these products as well. I'm not a fan of strontium. I don't recommend it. I caution people against using it for the following reasons. We have no safety or efficacy data on the type of strontium that is in the United States, which is strontium citrate.
Citrate, yep.
Every clinical trial on strontium was done in Europe on a form of strontium that was approved as a medication there called strontium ranelate. Now we can assume, for argument's sake, that strontium ranelate and strontium citrate are equally safe and equally effective, but I also like to be very honest of what do we know, what do we not know, and so what are we assuming? So let's just assume, for argument's sake, that they are equally safe and effective. With strontium ranelate, there are 6 large clinical trials that were done. 5 of the 6 only showed vertebral fracture reduction. It did not reduce hip fractures, which are the most dangerous type of fractures. And in the vertebral fracture reduction, it was no better than Fosamax in terms of about 43-45% relative reduction in risk reduction in vertebral fractures. But strontium also is a mineral that incorporates into bone, and it's heavier than calcium. So if somebody's taking strontium and they get a bone density test, that bone density test result is going to be false. It's not going to be accurate. Despite the limitations of the bone density test, I personally want the bone density test results to be accurate. The other thing is a safety issue, and that is in Europe with strontium ranelate, what they discovered in post-marketing surveillance data is that for every 1 fracture that was prevented, it caused a blood clot that could form a deep vein thrombosis, pulmonary embolism, and create a heart attack or stroke.
Right. Yeah, and that's my take on the literature too. And I recently actually did a review on this topic because I get asked this all the time. And I see so many people on strontium. And when I talk to the big advocates for strontium, the argument is they are, the ranelate and the citrate doesn't change the active ingredient, which is the strontium. And I say, okay, well, that might be true. We don't know that that's true. But let's assume that that's true. If we're going to assume that the strontium is the active ingredient that does the good, I think we also have to assume it's probably the ingredient that does the bad. And if that's the case, then do we really want to give this to millions of people? I think probably not. So yeah, I kind of came to the same conclusion.
Yeah, I'm glad to hear that. And I like the way that you articulated that as well. Like you can't cherry pick, and people I think are very fond of that. They like to cherry pick the data to
Right.
support their conclusion or what they're trying to sell.
Right.
And,
I mean, I get it. I mean, I understand I understand the thought behind it. I want to increase my bone density, but as we started out by saying, bone density is not the most important thing, and we don't really know what that increase in bone density actually means because it is just substituting strontium for calcium. What does that actually do to the bone? And there's all kinds of theories, but we don't know.
right.
Yeah. I wanted to go back to vitamin D. So you mentioned an appropriate level. Can you get specific on what serum levels you're looking for?
30 to 44 nanograms per milliliter is associated with maximum hip fracture reduction.
Yeah,
And
man, I'm so glad you said that. So I see right now there's a huge movement. I've been a big fan of vitamin D my entire practice. So in orthopedics, I was prescribing vitamin D to all my patients early on. I was very, very ahead of the curve. But now I see this movement in the kind of integrative functional space where, if a little bit's good, more is better. And kind of leaning on this like cancer prevention data, which I don't think is accurate. So now I see patients coming in on 5,000, 10,000, 20,000 IU a day, and their vitamin D is through the roof. And I actually have a study, I have it right here, a study that I'm about to review. This is old though, it's from 2019, but it basically said, higher is not better. So we have kind of brought that down as well. And our reference range, our optimal range is 30 to 50. So we're looking for that same group. Yeah.
Yeah, I do like it around 50, just a little bit higher than the 30 to 44. What's interesting, and back to the bone density piece, is we see bone density increasing as low as 9 nanograms per milliliter. So, but you don't see that fracture reduction until much higher.
Yeah. Well, and I think too, it's kind of a different question of like, are you taking D3 cholecalciferol to replace what you aren't consuming through food or potentially making through sunlight exposure, or are you aiming for a supraphysiologic dose? And I think those are kind of two different things. Like if you have a serum level of 9 or even 25, then yeah, absolutely. I think you're going to strongly benefit from bringing that up to between 30 and 50. But if you're already at 50, you're getting it from natural sources, do you need any vitamin D at all? I would say no, you don't.
I don't think so. And I think it's also important to understand that when you're looking at like the calcium and vitamin D, the research supports them. They both need to be there. They both need to be, you have to be getting enough calcium as well.
Yeah. Yeah, absolutely. So then I wanted to go back to one more thing, and we'll call that number 5. You mentioned nutrition, exercise, sleep, and you talked about Mediterranean. And I agree. I think the Mediterranean, if you want to define a diet, I think it's probably, it's the best studied. It's the best for everything, actually, it's ever been studied. So totally agree with you. One of the challenges I have with a Mediterranean diet is depending on where you read about it, what it includes can be quite variable. So I think it's funny that it actually performs as well as it does because it's not really clear what that means. So can you just get specific for me? So like kind of break down what you like to see people eat, how much protein, what kind of sources, other sources of nutrients. Just give us like, the top 3 or 4 things you like to see people eat on a regular basis.
So I created a system that I've been able to teach, patients and, thousands of other people called 3 Steps to Eating Healthy for Life. And it really breaks it down in just 3 steps. The first is I want people to not make any dietary changes initially and just track how many total grams of fiber are they getting for 2 days. Like write down what you're eating for 2 days, calculate how many total grams of fiber and how many grams of protein. Because I have people focus only on plants and protein, and plants have that dietary fiber. I want people to get about 30 grams of dietary fiber per day. And then the protein amount is based on their body weight. Like if people take their body weight in pounds and multiply it by 0.6, that'll give them the minimum grams of protein per day that they should shoot for. The amount of protein somebody consumes can account for 3% of bone density alone, just that. So that's how I have people focus on transitioning and eating this way. And you're right, it's a very, very different depending on where in the Mediterranean people are. But what does cut across all of those cultures and all of those countries is that they're eating very few processed foods.
Right.
They're eating fresh, whole foods. It's essentially a plant-forward diet that's very high in lean proteins, like fish and chicken, and very low in processed foods, lower in red meat than what we have here. And they also are, I don't talk that much when I talk about the dietary component, but within those cultures, there's also a big community component. And having a strong social network is associated with hip fracture reduction and better improvements. If you were to fracture, you healing faster. So being connected in community. But with respect to the dietary, what you're actually just eating, that's how I have people think about it, and then transition into eating that way over 4 weeks, 6 weeks, whatever's comfortable for them, because this oftentimes requires people to shop differently, have different snacks in the house. If their family's involved, everybody has to be on the involved in that. Cooking differently, maybe with different spices. And so this is really helping people transition into how they can eat to promote their health for the rest of their life, instead of just getting on a fad diet for a few months.
Yeah. Well, I think that's really well said, and probably a nice place to wrap this up. Right now my audience is scratching their head because my recommendations for protein are higher just based off of, different data. And I'm pushing people.
That's a minimum.
Yeah. I'm pushing people for more, and I say it differently. I say optimal. And for our patients, I'm sure you've seen this too. Most patients will come in, or most people will come in, and they're under consuming. And so I've heard people make the argument, well, if you just let them know, 0.6. I just had this long conversation with somebody in the kind of the menopause space, and she was like, look, we got to meet them where they are. So we say 0.6 or 0.8. And I said, that's okay. I believe that. But if we're going to tell them what's optimal, I think we need to tell them what's optimal. From my perspective, for most of our patients who are trying to build muscle and bone, it is closer to kind of 0.8 to 1 gram per pound. But we got to get them there, because they can't just jump to there because they can't digest it.
Well, and I think that's where dietary supplements are very helpful.
Yeah.
I am a believer this supplement should be used as the FDA intended, as a supplement to a healthy diet. And diet is always first, but there are situations where either the clinical trials support a dose of a nutrient that you simply can't get enough of in your diet, like MK4. You can never get 45 milligrams in diet. It's just not possible. That has to be taken as a dietary supplement.
Right.
With protein, getting a protein powder or protein drink to bridge that gap, I find to be very helpful.
Yeah, no, I agree. And we talk about all the details of that, so much, because it is getting the right product, avoiding the contaminants, avoiding the highly processed versions. It's such a challenge, but this is where the conversation could go on forever. So we've been going for about 45 minutes, a little more. So I think let's cut it off here. Any last words for the audience?
No, I just love your approach. I've loved the conversation to have somebody who's looked at the research in such depth and detail that you have, and are working clinically in this space, to be able to exchange ideas and talk about where we see things the same, where we might see things a little differently. For me, it's an exciting conversation, exchange of ideas, because there's always more to learn. We're always trying to learn in this space and trying to help patients get better, and the only way we can do that, because this information is not disseminated as widely as it should be, is through conversations like this, and so I really appreciate it.
Yeah, well, I appreciate you coming on the show and sharing with us your extensive history, because you've been doing this for a lot longer than I have, and certainly there is a lot more to learn, both just in existing literature but also in new literature to do. So I look forward to more conversations on that front.
Thank you. And if I may, I'd just love to just mention my website where people can find out more information about me.
Absolutely.
It's nbihealth.com. NBI stands for Nutritional Biochemistry Incorporated. nbihealth.com has articles on there, research, products, social media, how you can get in touch with me if people want to as well.
Yeah, awesome. And of course, if you haven't read the book, you should read the book. And it's Fracture Prevent Your Bones, correct?
Fracture Proof Your Bones.
Fracture Proof Your Bones. I was so close.
Yep. Thank you.
Awesome. All right, John. Well, thank you so much. And hopefully we'll do this again sometime, maybe over dinner or something like that.
I'd love it. I'd look forward to it.
All right. Thanks for listening to this interview with Dr. Neustadt. I hope you found that educational, and you can see how, even though we don't agree on all of the details of all the pieces we agree on. the most important things are clear. How we actually carry that forward to our patients, we're a little bit different, and that's okay because we travel in different circles and we look at different literature. So I really enjoyed that conversation. I hope to have more conversations with Dr. Neustadt down the road. I think that there's a lot of collaboration that can be done here between the two of us. That said, if you are still struggling to put together your bone health journey, please consider coming to our free masterclass. The masterclass, you can find the link in the description on YouTube or on our website at osteocollective.com. But the masterclasses are attempts to put together the 5 most common mistakes that we see as people are developing their own bone health journey and pathway. So I walk through those top 5 so that if you're making any of them, you can actually correct that without having to do anything else or consume any other content. So take a look for that link in the description on YouTube, again, at the website osteocollective.com. And remember that a diagnosis of osteoporosis isn't the end, but deciding to reverse it is a beginning. I'll see you in the next video.